Okay, good evening, everyone. I think it's time to start now. I would like, on behalf of UEMA, Iraqi Medical Association, to thank Student Iraqi Medical Association for this event. I'm sure it's going to be a fantastic one. They did a great job in arranging it with very high standard speakers. Thank you.
Thank you, Dr. Aziz. Thank you very much for helping us out with the event, and thank you to يما for the logistics and helping us reach more people with this event. مساء الخير لجميع الحضور، أشكركم لحضوركم اليوم. مثل ما دكتور عزيز said, أنا يوسف أحمد، رئيس الجمعية العراقية الطبية، وأنا طالب في كلية الطب في لندن في المرحلة الرابعة. يسعدني اليوم أني أرحب بضيوفنا الكرام دكتور طارق، دكتور صمد، ودكتور ياسر. أرجو منكم أن تغلقون الميكروفونات والكاميرات، وأي أسئلة ممكن تطرحوها على chat function في الزوم. I'll pass it over to Lena as well to introduce our next speaker, who is Dr. Hameed.
Our second guest for this evening is Dr. Yasir Hameed, who is a consultant psychiatrist based in Norfolk, who specialises in adult and old age psychiatry. And he's also an honorary senior lecturer at the Norwich Medical School, who I've had the privilege of being taught by. Without further ado, I'll just pass on to Dr. Yasir.
So, my talk for the next half an hour or so will be around the mental health of older people who are from refugees and asylum seeking background. Simply because I am a refugee, I became a refugee when I left Iraq in 2005 and registered with the UNHCR when I was living in Yemen. And I think, UNHCR still have my record and the record of my family. So I am a refugee and I'm an old age psychiatrist. So this talk brings both of these things to you, which is, as I said, my background, my personal experiences and my professional background. One of the things that I wanted to focus on in this talk is not only about older people. I'm going to talk in general about trauma, but definitely with more focus on older people and how we can help them to cope with the traumatic experiences they went through before coming to the Western countries. What are the challenges that face older people when moving to a new home in a new country, and how we can help them? I also wanted to put some learning objectives here. So first of all, we are just going to talk a little bit about mental health of older refugees and asylum seekers and why they are more vulnerable compared to the other age groups of refugees and asylum seekers. And then I will discuss two cases from the clinic. I've seen them in the clinic. So I have been running a clinic, which is voluntary clinic, once a month to see refugees and asylum seekers who have been resettled in the city I work in, which is Norwich. So unfortunately, the clinic stopped last year because of the COVID situation. But for 3 years, I used to do this clinic based in primary care, where I would go and see those patients and then follow some of them up. Those patients will be typically presenting with more complex mental health difficulties that the GPs will find it difficult to kind of treat or manage, but also maybe they have difficulty in accessing the secondary care services. So, my clinic was an attempt to bridge this gap between primary and secondary care services for those patients. So we'll talk about two case presentations and then recommendations of how we can improve services for this group. Before I wanted to just go into the really the literature and the research behind mental health for older refugees and asylum seekers, I just wanted to give you a little bit of background about my personal experience of growing up in Iraq and living through the war in 2003 and then leaving Iraq in 2005. And I think this is one of the most difficult things I ever do, to talk about my personal experiences. But I think in this talk, it just gives you a bit of context about why I am so passionate about this issue, but also why am I am I so hopeful about the future? Because as Sarmet said in his talk, there is a lot of hope as well. We don't want to really tell you about how awful it is to experience traumatic events. I do believe that there is hope, and that, you know, these experiences will make you a stronger person and will inform your professional life as well as your personal life. So yeah, so in 2003, you know, I was a junior doctor working in a tertiary trauma center. So it was a kind of a center for plastic surgery and reconstructive surgery, including kind of orthopedic surgery. And just before the war, we decided to form an emergency department to receive the kind of the wounded, the injured people during the war. So there was an anticipation that we will need more emergency facilities to cope with that, you know, with the war. And I remember working in the hospital on the 9th of April, which is the day that the American army entered Baghdad, and there was, you know, a lot of wounded people, a lot of kind of people who were killed, civilian, and also from the Iraqi army and others who were resisting the American army. And on the 10th of April, when, you know, the Iraqi army disappeared and the police forces disappeared, there was complete chaos in Baghdad and throughout Iraq as well. And there were, you know, lots of kind of looting and destruction of government buildings and hospitals. And I remember I was working in the hospital at that time, and between the 9th of April and the 10th of April, I saw, as you know, the largest number of dead people in these 2 days. I can't recall how many, because we were just really taking the people who arrived dead to you know, to the back of the hospital, and then trying to do our best to deal with the injured in a big lobby in the hospital. So there was no proper emergency department facilities. And imagine the trauma of being in that situation. Imagine, you know, the smells and the noise and the shouts and the cries and the blood everywhere, you know, and you being there as a doctor or as a nurse and trying to help people while you yourself is going through, you know, one of the major traumatic events that could ever happen to anyone. So I was working there in the hospital, and then we admitted a British citizen. So he was part of the journalists who were injured during the American invasion. So they brought him to our hospital, and suddenly this British citizen became the reason why our hospital continued to work, because the American army protected our hospital from the looters, while they didn't do that to other hospitals, for example. And on the 10th of April, we were visited by many journalists. One of them was Dexter Felkins from the New York Times. So he visited us, he interviewed me, and he interviewed some of the patients who were in the hospital. And this is the way he described the hospital that I was working in at that time. So I'll just give you a few seconds to read his really real description of the situation of our hospital on that day, the 10th of April. And then when I was dealing with, with all of my duties as a doctor, the looters were trying to come into the hospital. So they already been in the government building, which was behind our hospital, and I can hear them shout, and they were so excited, destroying everything and looting everything from the building behind the hospital. And they were trying to jump the walls of the hospital to come inside. This was just before the American army make their way to our hospital to protect it. So a few hours before that. So what I did, I went to the to the person who was sitting in the reception office. And in our hospital, we had an AK-47 weapon. So I told the person, can you go out and just, throw some bullets in the air or something, just let those looters scare and leave us alone. And he said, no, doctor, I'm not going to do that. So I had to make the decision of taking the AK-47 from the receptionist and just kind of shooting some bullets in the air just to scare the looters. And this was successful. But, the journalist was there and he documented what he saw in his book and also in his article he wrote in the New York Times about me pulling out the gun and kind of shooting in the air to disperse or deter those looters from coming into our hospital. So again, imagine going through all of these kind of experiences and kind of just trying to do the best for your patients and your colleagues. And running on an autopilot, you don't feel much at that time, but it leaves you with so many kind of memories later on. But despite all of these experiences, I never say to my patients that I know exactly how they feel. I will be lying if I said that, because these traumatic experiences affect each one of us in a completely different way. So yes, these experiences, will give you better understanding of the human suffering, of the human emotions, of the human resilience as well. It gives you a lot of empathy with people as well. But you can never say that you know exactly how they feel, because you can't. Each person is different. And also through this work, I was able to co-write a chapter in this textbook, The Seminars in Old Age Psychiatry, specifically around the mental health of all the refugees and asylum seekers. And some of the slides in today's talk will be based on that chapter. But for the refugees and asylum seekers, when we are thinking about the WHO, the UNHCR, the UN High Commission for Refugees, they have chosen a slightly lower value. So they use the age of 60 years old. So that's a little bit lower than the Western kind of cutoff of 65. As we mentioned, people as young as 50 could be considered older because of the kind of the traumatic experiences they have gone through, or because of even lack of access to good primary health care, where they would be able to manage kind of things like high cholesterol or high blood pressure at a younger age. So you will see that they will have more physical problems even at the age of 40 or 50. You are absolutely right. So younger people have less disabilities and needs, more able to adopt, leave danger zones earlier, and less vulnerable. Yeah. And of course, the issue of racism, it affects everyone. But typically older people will be more vulnerable to racism because, again, of the difficulties we spoke about earlier, is that they are more difficult to integrate, have more difficult with culture. Maybe they prefer to be living in a closed community, so they are not very open, and that can make them more vulnerable to racism, for example. Okay. So I just wanted to show a quick video. I hope it will work.
لأنه هلا الجيل كل شيء الولد بسوريا تشبع بالدم. البني آدم من قطع رأسه قدام الطفل الصغير يعني بيصير عنده شهوة القتل. أما هون في أمان، في تعايش مع الآخرين، سعادة، فرح، كل شيء موجود مأمن له.
الوطن مثل الطفل لما تربيه أمه. نرجع لسوريا ولا احنا مرتاحين مستقبل يعني بشكل هنا، مثل هالطفل اللي ربته امه يتركها ما يتركها، بده يعيد عليها.
كل البلاد تكون آمنة والشعوب ما يصيبها شيء ويمر، بل احنا مرينا بيه.
طبعا هالبكي هذا بكيناه كثير يعني قبل لما بينقتل واحد منا، لما بشوف بلدنا تدمر.
عندي 5 أولاد، 4 وهذا كلهم هنا بألمانيا تشردوا بيع ما يندلون أولادهم عيالهم كل واحد لحاله.
Yeah, so you can see, they are one family. They went through probably the same traumatic experience, you would argue, but the difference in the way they process these traumatic memories is quite different. And the young person was talking about, how much these experiences have affected, the children, seeing people decapitated. But the grandfather was talking about how can you leave your mother, the homeland is like the mother, so, completely different kind of perspective looking at the same issue. So, yeah, I just wanted to show this, to show you the difference in narrative within the same family about these traumatic experiences. The first one is a 45-year-old Syrian refugee. I saw him in my clinic just a few weeks after he arrived in the UK. He was really kind of caring for his wife, and his son was caring for him. So this really interesting dynamics in the family. His wife had cancer and had treatment before they came to the UK, so that affected her physically. So he was caring for her, and he wanted the help of his son to do pretty much everything in terms of arranging their daily life, their meals, their shopping. He was presenting with various physical symptoms, so pain, declining mobility, insomnia, some cognitive difficulties as well, and also was experiencing social isolation, spoke about various traumatic memories from the war, being shot at by snipers when they were trying to flee their village. So he was referred to me because the pain clinic, the GP were really at loss with how to deal with this gentleman's difficulties. So really, this is a list of the problems, and I should mention, in addition to these problems, there was a stigma of the mental illness. So he didn't want really to see me in the first place, but then he accepted that, but then he would never accept any medication. So how to deal with that, I will leave this to Professor Tariq Al-Kubaisi in the next talk about how to address trauma. But again, just something to think about when you are dealing with these patients. How can you overcome these difficulties and help them? This is a little bit about Maslow's hierarchy of needs and the importance that I usually use this to explain to my patients when I see them in the clinic, that when they came to the UK, they are starting all over again from the base of the pyramid. So they need to focus on their essential needs and build up their abilities to reach to the self-actualization stage that they may have achieved back home, but now they have to restart it again. And the second case, again, it's about a lady from an Asian country who came to the UK in 2016, escaping really domestic violence. So there was no war situation there. And again, she was presenting with cognitive difficulties, lots of physical health problems. And she was referred to us repeatedly by the GP. She wouldn't engage with the well-being services or the psychological therapies. She has accepted antidepressant medication, but that led to more problems physically, so we had to stop it. And when I kind of seen her, I remember this concept of having a quadruple jeopardy, having multiple factors affecting you. And in order to help this person, you need to address each of these factors at the same time and not separately. So again, my sincere apologies, but you will have the slides and then you can learn more about these challenges and how to overcome them when working with people who are older, from a refugee or asylum seeking background. And I think what Sarmat said about raising awareness is such an important issue. Training is really important, and also having more people from ethnic minorities in delivering services for those people. So I'm really very pleased to see that we have so many medical students from ethnic minorities, but we need more in the police services, in the immigration services, in the social services as well. And so, there are more recommendations there, but this is what I wanted to leave you with, which is a picture of hope. This is from Ella Baron, who is an illustrator, worked with The Guardian, and she went and kind of worked in refugee camps in Lebanon, and she was really touched by the amount of hope that the refugees had. And she put that nicely in this picture, that despite all this chaos around us, there is always hope. So I'm hopeful that things will be better, and those people have magnificent resilience, really, and we should build on their resilience. Thank you.
Yeah. About your own experience and your own outlook, because obviously you've gone through quite a lot, and you've shared very generously your own experiences with your own family, and how's that impacted you as a person, and going through that process yourself?
So definitely these experiences informed my decision to be a psychiatrist and to be someone involved in the care of people surviving these traumatic events, because for me, the best way to deal with these experiences was helping people who are going through them. And that's how I made something positive out of these negative experiences. But they do affect you. There are days when I feel so sad and so angry that I cannot go and visit my country every time I want. Really, the last time I've been to Iraq was 2 years ago. So it is a sense of really loss. But as I said, you are trying to turn it to something positive, if that makes sense.
Yes, absolutely. Thank you very much. So I've got some other questions now flooding through. So I'll just go through that, if that's okay. So Zayeb asks, can traumatic memory fragmentation and suppression be difficult to differentially diagnose from the onset of age-related memory decline and neurodegenerative disorders?
Absolutely, very, very difficult. And I've seen really several patients in my clinic, and we wanted to do cognitive assessment, and we couldn't, because especially this lady, nicknamed Sumaya for this presentation, she was presenting with lots of short-term memory problems and disorientation. So she would wake her children up at 4 o'clock in the morning, thinking that this is the morning and they need to go to school. So it was really difficult to disentangle which of these symptoms are related to her maybe traumatic experiences and which are related to a new onset cognitive impairment. So as I said, it's really difficult. We don't use the usual kind of cognitive testing tools, but we use some modified cognitive testing tools for people whose English is not second language. But even these tools cannot really be very reliable in this population. So it's difficult, but it will depend on your experience, and some collateral history from the family as well will help you in disentangling this.
Thank you very much. Yasmin asks, Assalamu alaikum, thank you very much. Do you find a difference in how many people manage trauma in Iraq and in the UK?
Definitely. So in Iraq, for example, you have kind of strong spiritual life. So people will kind of seek help from religious kind of figures, or doing religious rituals and things like that. While in the UK, there are not many kind of inclination to do this. But I've seen it here as well, is that when they come here and they are from a Christian or Muslim background, they will seek a local community, where there is a church here in the UK, or there is a mosque or another community center, and they will be able to to go there and overcome their loneliness and isolation. So I will say religion plays a lot of a big role in coping with traumatic experiences back home, and it can also help those refugees and asylum seekers to make sense of their difficulties, and also creating a community for them.
Thank you very much. May asks, how do you overcome treating individuals who are clearly traumatized but reluctant to accept mental health treatment due to stigma and the cultural barriers that stop them from acknowledging their mental health?
I can tell you many people I would see in my clinic month after month, and they would refuse referral to well-being or psychological services. They would adamantly refuse any antidepressant medication. They feel that these medications are addictive. But basically what I have done, I just keep meeting them. So I'll just say, okay, let's see how things are next month. Try to do this, try to go to the local center, try to do a bit of walk. So you try to approach it from a non-psychological and non-psychiatric way, hoping that they will eventually get better and they will eventually get over this without the use of conventional treatment. But yeah, it's a big hurdle, but with therapeutic kind of work, you will eventually get them to accept that, there is a problem and there is a need for treatment.
Thank you. And we've got a bit of a long question here, but we'll try and split it up. So what do you think of the intergenerational trauma and epigenetic? And the second part is, how do you think traumas experienced by your clients, for example, impact their children in second and third generations?
Yeah. So that's a good question. So basically the epigenetics is when your genetic makeup change because of the kind of the circumstances you are living in. It is such a big thing. What we know is that parents, will often talk to their children about their traumatic experiences. And that can be difficult for the children to make sense of it because they didn't live it. They even don't know maybe the country, they haven't been in that country. But what we think is useful is that choosing the right time to tell the children about these things and choosing the right tools to tell the children about this is a very therapeutic thing. Because, if you bottle this up in yourself and you don't want to talk about it to anyone, that can make things worse. But as I said, choosing carefully how you say to your children about your traumatic experiences and how to keep them kind of aware about their roots and, their culture is really helpful, rather than kind of just becoming very quiet and silent and just telling children, look, you are here, just live as you are, citizens of this country without thinking about the past. And the second question was?
Yes, so the second part was, how do you think traumas experienced by your clients, for example, impact their children and the second generation or third generation?
Yeah, it definitely impacts them. As we said, so we have the concept of the epigenetics. So if you are exposed to serious and repeated trauma, that will affect the children genetically. That will make them maybe even more susceptible to developmental illness later in life, despite the fact that they would have never lived your experiences. So this comes the importance of being aware about kind of mental health issues and how these are manifested in younger people and in children as well. And this why it's very important to kind of teach the parents about this. And this is what we have done with the Syrian refugees, is that we told them a little bit about mental health in various age groups and how to seek help. Because yes, the children will be affected either directly or indirectly by their parents' experiences. And we need to empower parents and children about seeking help and recognizing that.
Wonderful, thank you. And another question, how would you think you'd have reacted with everything that you've been through if you were a different age, for example, if you were a teenager?
Yeah, it's a very difficult question because I was a teenager in Iraq in 1991 when the Gulf War started as well. So I would say that I would have coped with it better. Because as I said, with teenagers, with younger people, their whole life is in front of them. And as long as you give them opportunities and the right tools, they will get better. while being an older person going through these difficulties will make it really very difficult to overcome them or just leave them behind and start a new life. So I would say I would have coped worse with them, better with them if I was a teenager. But again, you know, everyone is different, and this is why I said in my talk, I never say to patients, I know exactly how you feel, because I don't.
And then finally, we've just got time for one last question from Louise. So thank you, Dr. Hameed. How can healthcare professionals contribute to changing UK asylum policies and processes that these promote individuals' well-being rather than being detrimental to it?
It's very difficult because I work as part of a group as well who are interested in doing and supporting refugees throughout the UK. So, you know, the UK immigration system for refugees and asylum seekers is really harsh. It increases probably the incidence of mental health problems because of the repeated rejections of asylum applications, putting them in detention centers, for example, making everything worse. It's very difficult to change the system, but we have found that raising the awareness of professionals about these difficulties can help. Why? Because number one, you can help your patients better if you are more aware about these issues. You can write letters to the immigration authorities, you know, commenting on the mental state of your patients, commenting on the negative consequences of the rejection decisions or on detention. And therefore that will make the immigration authorities kind of listen more to professionals. So we have done this work, and we do a little bit of work about kind of training for immigration officials. But yeah, it's a big thing. But you know, we cannot change the immigration policies, but we can change the way we support those patients and make the immigration authorities more aware about the impact of their decisions on the mental health of our patients.
Wonderful. Well, thank you very much for your time, Dr. Hameed. I think a lot of people really enjoyed that.